Hi, everyone, and welcome to the Crawford Brief, where we focus on informed analysis and timely insights in the field of urology. Joining me to discuss an important breakthrough in the management of advanced prostate cancer is Dr. Maha Hussain. Maha is a colleague and good friend who is a professor of medicine and deputy director of the Robert H. Lurie Comprehensive Cancer Center at Northwestern University in Chicago. She is an internationally recognized expert in genitourinary oncology. Her research focuses on advancing treatments for prostate and bladder cancer. Just recently, the U.S. FDA approved Nubeqa, darolutamide, to treat patients with metastatic castrate-sensitive prostate cancer. And Dr. Hussain, thanks for joining me to discuss this. What they said in that press release is that this is the first and only ARI approved for metastatic castrate-sensitive prostate cancer with and without chemotherapy. I was involved with the ARASENS trial, which is the chemotherapy trial, which we published in New England Journal of Medicine a couple of years ago, which was a game changer. Based on this phase 3 ARANOTE trial with over 400 patients, there was a reduced risk of progression or death. And we want to talk about this. What does this mean to you as a medical oncologist who is a world leader in prostate cancer? What are your thoughts?
Well, first of all, Dr. Crawford, thank you so much for the opportunity and for including me in this conversation. I do think anytime we have more choices for patients, that really has a direct impact on how we take care of patients. And as you know, we've come a long way from the old days of, flutamide and bicalutamide. If you recall, you led the first, trials at the time.
A long
Clearly,
time ago.
yes, yes. We've come very, very long way, and I do think we're impacting the care of patients. I do think having more choices helps us better tailor treatment for patients, at the individual and patient level based on their different factors, their age, their comorbidities, and other factors.
So let's talk about this evolution of care from monotherapy to you mentioned our really pivotal trial we published back in 1989 with the first
Yes.
generation anti-androgen. Now we're really in the third generation. We actually sort of kicked this can down the road for decades of monotherapy, and now we have doublet
Yes.
therapy. Do you think that is clearly the standard of care right now for patients
Yes,
with
yes.
prostate
I think
cancer?
that definitely, I think what is clear is this: historically, we knew that mechanisms of progression with prostate cancer is driven by adaptation and then obviously resistance. Not every cell is going to respond properly and adequately and get killed by the androgen deprivation. So clearly, trying to maximize the deprivation by adding an AR inhibitor or AR pathway inhibitor is going to, what I tell my patients, is going to starve the cancer. Ultimately, however, there are cancer cells that guys kind of goes dormant and then decide to wake up and grow. And there are some cells that are not necessarily getting, they're potentially resistant to AR deprivation or, androgen deprivation and will grow. So to me, intensification of the treatment has really made a huge difference. When you look at it, when we started, let's say in the 80s, the median survival of hormone sensitive patients was on average about 2.5 years. Now we more than doubled that. And I do think there's much more, room to improve.
But this is a lesson we've learned from a lot of cancers, don't you think? Is that you don't really, well, first of all, earlier is probably better than later in the disease state, in the advanced disease state. And also that when you think about the cancers you cure, testis cancer is one. It's not platinum alone, but it's platinum, Velbam, bleomycin, or some other combination. Lymphoma is the same thing. So it's
Yes.
not surprising. But there are a number of different doublets out there right now, and it's great. And, I look at this trial as a very important trial. It sort of reminds me of the Neil Armstrong on the moon, a small step for man, big step for mankind, sort of paraphrased. this is another arrow in the quiver here of, hey, look at, we've got a lot of to have to think about doublet therapy and should for prostate cancer. Let's move on to triplet therapy. That was the one that was done, the Arison's trial, and that
Yes.
followed up on the Sweeney trial. Triplet, but it is a little more aggressive than doublets. What are your thoughts? And I guess this to finish up here, what's the added toxicity and how do you select patients for this?
Well, I think one of the things is this: anytime we deal with medicines, we balance risks and benefits. Life itself is full of side effects. The reality of it is this: you're going to have to handle the issues with cancer, and cancer doesn't care, as I tell my patients, how we feel about things. The critical part is going to be deciding, is the patient fit enough to receive triplet? Is the triplet an absolute must give in this setting? So I do use certain criteria myself in clinic. And just for disclosure, I was part of the steering committee for the Arison's trial. When we designed it, at the time, the data that was available was basically doublet with chemo. Most of the other doublets were not, or triplet treatment. The question comes up, did darolutamide and ADT by itself would be a good arm or not? And there was a lot of discussion at the time. Obviously, now we've come a long way, but I do think situations like patients who have de novo metastatic disease, so that's as they get diagnosed, their fresh, frontline diagnosis was metastatic disease. That to me is more aggressive. Younger patients, healthy, I tend to favor the triplet with them. Of course, there are a lot of subtleties. The issue comes up, the volume of disease and things like that. Patients with high volume, I generally favor triplet, unless obviously they are, older or frail and things like that. So all of these things are factors. When it comes to the doublet, and I'm glad now we have the FDA approval for darolutamide, because prior to that we had abiraterone, obviously Enza and APA. I think the issue comes up is going to be, again, is the patient fit enough for triplet versus doublet? And if that's the case, then there are two options for triplet: the triplet with Abi or a triplet with darolutamide. And to me, giving darolutamide is much simpler because you don't have to worry about issues of the steroids and other potential side effects.
Hmm. Well, it's certainly exciting to have all these options we didn't have.
Yes.
I sort of grew up, it's hard to believe, and you were part of it the early era when we had bilateral orchiectomy, had
Yes.
estrogens, and now we've really come from the first generation antiandrogens and androgen receptor inhibitors, we call them now, to really, I consider it third level of them. Just one last thing about the added toxicity. Let's look at this doublet therapy with darolutamide. Are we adding a lot of toxicity by adding darolutamide to ADT?
Well, I think that anytime you add something, there's going to be side effects. The reality of it is this: is the totality of the picture, the impact on life and overall, and the potential for prolonging life in an individual. And definitely, we work with, we're fortunate enough to have a pharmacist. We've always had a pharmacist in the clinic with us that would help us with regard to drug-drug interaction and things like that. So is there toxicity? Yes. But the biggest toxicity we worry about is cancer out of control.
Yeah, that's a great statement. Yeah, there have been studies done asking patients what they want with their therapy, and I remember one with lung cancer that giving the more aggressive treatment increased life expectancy by a few weeks, and they wanted it.
Yeah,
It,
absolutely.
it yeah, it's really nice having all these options available
Yes.
right now. I want to thank you for your time. This has been a great discussion. I think we've had the opportunity to cover a major event in prostate cancer treatment, and we're looking forward to hearing more as we dissect this and other studies. Thank you, Maha.
Thank you very much for the opportunity. We've come a long way and more to come.
Thank you.